Good afternoon. Welcome to Grand Rounds. Today's speaker is Dr. Lauren Hughes. She did her undergrad work at Iowa State, got a master's in public health at George Washington, and an MD degree at the University of Iowa. She then did a family medicine residency at the University of Washington, and then an RWJ clinical scholars program there, where she got a master's in health and healthcare research at the University of Michigan. She was a health policy intern with former Iowa Senator Tom Harkin and was a visiting scholar at the Center for Medicare and Medicaid Innovation. She started her faculty career as a clinical associate at the University of Pennsylvania and is currently a visiting associate professor at the University of Colorado Department of Family Medicine. She has served as the president of the American Medical Student Association. She's currently on the board of directors of the American Board of Family Medicine. She has been deputy secretary for health innovation for the Pennsylvania Department of Health and is currently the state policy director for the Farley Health Policy Center. That is a center in the Department of Family Medicine at the University of Colorado. They focus on workforce development, medical finance and payment policy, system transformation to integrate care, community-based prevention and well-being, and social policy to address disparities. And today we're going to hear about rural health. Dr. Hughes.
Thank you very much, Dr. Albert. Really appreciate the introduction. And thank you to you and your team for inviting me to speak today on one of my favorite subjects, which is strengthening rural healthcare delivery, both during COVID and in the post-COVID world. So I'll start first by reviewing the 3 learning objectives for today. The first is to appreciate the magnitude of rural versus urban health disparities and the frailties in rural healthcare. Number 2, to understand the factors that have contributed to resiliency in rural communities during COVID-19. And number 3, to identify rural health policy solutions designed to achieve equitable health outcomes. In terms of disclosures, I would like to disclose that I received funding from the Zoma Foundation and from CPSI to support the development of the Rural Health Playbook that will be discussed during the presentation today. I have no other disclosures to report. Before I jump into a clinical case, allow me, if you will, to spend a few slides discussing critical background relative to rural people and places. Starting first with a definition, which you can kind of see here is a tall order to be able to do. If you think of rural places, I'm sure that various different images are conjured in your own heads. For me, I'm originally from rural Iowa, so I appreciate that rural Iowa, now living in Colorado and doing work in rural health research and policy, not the same thing. Not the same thing as rural California or rural West Virginia. And certainly rurals within the same state are incredibly different. For example, last week, I served on an American Hospital Association Rural Hospital Leaders Conference and was on a panel with 2 rural hospital CEOs from here in Colorado, one from Vail and one from Holyoke in northeastern Colorado. As you can appreciate, those 2 rurals are not the same types of rurals. At the federal level, rural is defined or classified with specific criteria in more than 30 different ways by agencies, offices, and government divisions, such as the Office of Management and Budget, the Census Bureau, Health Resources and Services Administration, Department of Labor, Department of Energy, and so forth. I mention this because it's important to keep in mind the extraordinary diversity that is rural across different regions and states. Let's also talk about myths regarding rural people and places. This is one of my favorite activities in many ways, is to debunk these myths whenever and wherever I can do so. The first is a myth that comes up about every 4 years in tune with presidential election cycles, that rural America is somehow synonymous with just the heartland or Midwest. Could not be further from the truth. Rural Alaska is rural, rural South Carolina is rural, and neither of those are anywhere geographically close to the Midwest or the heartland. Rural America is not one white conservative monolithic voting bloc. This is easy to maybe come to this conclusion based on what is portrayed and discussed in the media, but again, could not be further from the truth. 20% of Americans live in rural places across the country, and they live in a landmass that comprises 95% of the US landmass. So they cover a diverse and wide territory. 1 in 5 of those rural Americans identify as being a person of color or a Native American. And with immigration and migrant farm labor, et cetera, the diversity of rural America is changing. Number 3, rural economic development is not synonymous with agriculture. These two things are often conflated. It's important to remember that rural economic development includes much more than just agriculture. Mining, IT, manufacturing, healthcare, of course, tourism, many other avenues for economic development. Number 4, the personal choices rural people make are not solely responsible for their poor health status compared to their urban peers. It's important to take a step back and to appreciate that in a community where a rural population lives, what are the policies, systems, and structures that are in place that impact the decisions that are then available for them to choose from? Thinking along the lines of food and housing policy, for example. Each of us are only able to make the healthy choices and from those choices that are available to us. Number 4, rural communities are not doomed to fail. In my work in rural research and rural health policy, I often hear of rural communities being framed from a deficit perspective, as opposed to appreciating the extraordinary assets that rural communities have at their disposal to innovate and care for their populations. And we'll talk more about that later on in the conversation. Number 5, life in rural America is not somehow more authentic or real than life in urban areas. This is a myth is particularly amusing to me because there isn't one lived experience that can claim to be more American than another, rural or otherwise. And last but not least, rural Americans are very capable of solving their own problems, whether that's in healthcare or in other sectors. One of the many challenges that rural Americans do face is lack of relative resources, comparatively speaking, to their urban counterparts, especially long-term investments in improving health and infrastructure, as well, and especially if we focus on the healthcare system. Rural healthcare leaders are often challenged by lack of bandwidth and by challenges in capacity with time and ability to acquire new skills to lead in different or more innovative ways. Let's talk briefly about disparities and challenges that rural communities faced entering COVID-19. In terms of health outcomes, rural populations are comparatively older and poorer compared to their urban peers. You will see higher rates of depression, heart disease, stroke, diabetes, cancer, obesity, tobacco use, and unintentional injury, comparatively speaking. Prior to COVID, there were 2 public health crises that we were tracking closely, and these have not gone away in light of COVID-19. The first is rising maternal and infant mortality, and the second is the worsening opioid crisis and the coincident increases in certain pockets of the country of rising HIV and Hep B and Hep C rates. Rural populations are less likely to be insured and less likely to work for an employer that offers insurance as part of their benefits package. And they're more likely to carry debt from a medical emergency should that occur. In terms of healthcare systems, the first item that I have listed here obviously is not applicable to only healthcare, especially over the past year where access to reliable broadband and internet coverage has been critical, not just for being able to work remotely, if you're able to do that, for education, for acquiring needed goods and services, for staying in contact with friends and family. It's been critical in healthcare in terms of access to needed services via telehealth. But we certainly face significant digital divides between rural and urban America. And I think if anything that the past year has demonstrated to us is that the criticality of broadband really should be thought of as a public utility in terms of its importance in modern day society. In rural America, you have less robust social safety nets to address the social determinants of health that are important to improving health and well-being. Rural healthcare delivery systems, both hospitals and primary care practices, are squarely at the end of the supply chain on a good day. We've heard the stories of and the real challenges on the ground of these delivery systems having to fabricate their own PPE, including volunteers sewing masks and collaborating with local manufacturers to 3D print face shields. These systems have had to reuse PPE and to be very creative about going after other types of supply chains, whether that's agricultural supply stores, painting stores, auto, veterinary suppliers, etc. The next item is also not applicable only to rural. Clearly, a vast majority of payment in our healthcare system is still tied to volume and fee-for-service. And in rural America, for a variety of reasons, you have declining patient volume that is hitting these rural healthcare delivery systems in light of, or at the same time as you're seeing increased operating expenses. So the per unit operating expenses in rural healthcare delivery systems and declining volume of services set up some precarious financial positions for a lot of rural healthcare delivery systems entering COVID-19. We have fewer healthcare providers in rural America, and those that we do have tend to be older, and many are nearing retirement, which has been particularly challenging during COVID as these older providers, they themselves are in a higher risk category for COVID-19 infections and complications. It can be difficult and costly to recruit and retain a healthcare workforce in rural America, which further exacerbates operating expenses. And since 2020, according to the Shep Center at the University of North Carolina, 135 rural hospitals nationwide have closed their doors. This has been predominantly in the South and the Southeast, although many states are not immune to this trend. Clearly, this cuts off access to healthcare services locally in their communities, meaning that patients and their family members are having to drive longer distances to get care. This may set up a situation where there's delayed care, delayed diagnosis, greater or additional complications. But from an economic standpoint, when a rural hospital closes, those individuals that had the higher paying, often college educated jobs in that community are starting to commute to other communities for their work and for their livelihoods and may choose to move, destabilizes the local tax base for public services, and also makes it more difficult to attract other industries to the community when you do not have reliable access to local healthcare. And in terms of capacity relative to COVID-19 and complications, there are generally fewer ICU beds per capita in rural America. In all of the research and policy that I have been tracking over the past year, this perhaps is my favorite graph or chart that I have found. This was published in June of last year by Dr. David Peters, who's a rural sociologist at Iowa State University. And what he was doing in this study was to track and sort of score susceptibility across the different sort of geographic regions that you see on the screen relative to the 7 key factors: compromised health, population over 65, the presence of nursing homes, meat processing plants, population density, group quarters, and diabetes risk. Clearly, we'll focus on what's encircled by the red, the micropolitan, semi-rural, and rural. Of note, the definition of micropolitan by the Census Bureau is a small town with at least 10,000 population, but less than 50,000. Let's track the brown indicator, which is population of age 65. When you go from left to right, you can see that as you move from a large metro to a rural area, that by the time you get to a rural area, the older population dramatically increases. It's a positive score, a positive number, dramatically increases the susceptibility to COVID. In the semi-rural areas, you can see that group quarters played a significant factor in increasing susceptibility. This is defined as presence of college, prisons, and military barracks. And in micropolitan settings, you can see that meat processing plants, led to greater susceptibility in those areas. I think what's dramatic to see is a distinction, and we know this based on our lived experience over the past year. But in large metro areas, such as Denver and other large cities, that the greater susceptibility to COVID is due to population density. But that's a different story when it comes to micropolitan, semi-rural, and rural areas, which sets up pockets of different types of vulnerability in rural places. So let's talk about some rural health realities during COVID-19 that are important to discuss. Last summer, I conducted extensive interviews with rural healthcare leaders across Colorado, and they overwhelmingly shared that in March, April, May, as we were just beginning to grapple with this new public health emergency, that early on there was extensive support, understanding, and volunteerism to support the hospitals and local primary care practices. But by the time you got to June and July, that early cooperation and understanding gave way to anger and frustration in certain communities as the economic worries became more pronounced than potential health consequences of COVID-19. There are 3 points that I'd like to make relative to this distinction or this transition. The first is to appreciate that rural America, the recovery from the Great Recession of 07 to 09 has not been equitable across the country. And in many places, rural America has been slower to recover from the Great Recession. Number 2 is that rural America, you find a lot of vulnerable industries, such as meatpacking or childcare, manufacturing, that may be jobs that there is no ability to work remotely from home. I am not certain how, for a vast majority of jobs, would be at a meat processing plant or a poultry processing facility, how one could work remotely at home to do those kinds of jobs. In addition, there are a lot of industries in rural America that come without paid sick leave. And so you can imagine that, if you need to work to pay your bills and put food on the table, that's what you're going to do, even if there are recommendations to not come to work if you're feeling sick or ill. In addition, there are immigrant workers and populations in certain areas of rural America whose living and commuting realities make social distancing or physical distancing more challenging, particularly if they're living in multi-generational housing units. By the time we got to last summer, there certainly was growing resentment in rural Colorado and other rural places around one-size-fits-all public health orders that didn't contemplate local disease transmission dynamics. Important to remember that in some of our ski resorts that, in March, we were seeing cases. Well, we had international travelers that we suspect that brought COVID with them when they came for spring break. But you then had other rural communities that were engaging in public health orders and sheltering in place and staying at home orders, and had their businesses closed for 3 months, and those towns and those communities didn't see any cases until June and sometimes July. So you can appreciate the derivation of this resentment and where that came from. And then certainly politics in the pandemic, politics and public health, rural places are not immune to the impacts of those 2 things. And that led to a breeding ground for misinformation and conspiracy theories that certainly have been challenging to combat on a number of fronts. And then specific to hospitals and primary care and what their experience has been, their realities have been during COVID. It's ironic that at a time when these rural communities need these entities the most, that they were at risk of paradoxical layoffs, again, largely due to our fee-for-service structure and sharp revenue drops that both of these entities experienced, largely from stopping elective procedures and outpatient care in March, April, and May. These entities also faced cash flow difficulties as well as price gouging. And it wasn't just on personal protective equipment, but also on access to needed medications and to agency staffing to try to get in some cases, get nurses to take care of patients was an extraordinarily expensive proposition. So I spent the last few slides talking about some of the challenges of rural health and healthcare delivery. Let's talk about the very real assets that can be leveraged to identify and solve challenges in rural America. The first is a sense of independence and self-reliance. A lot of rural people choose to live in rural places for these very specific reasons. This is a spirit that can be leveraged to improve health and healthcare. Rural America, as I mentioned earlier, also does not have an abundance of resources, and which means that they make do with what they have to solve their problems. Again, another characteristic that can be leveraged. Community social capital. There in a lot of rural communities, extensive sort of social fabric, looking out for one another, neighborliness. Again, that is a positive, it is an asset that certainly has been challenged over the past year because of COVID, because of our political and social challenges that we're working through as a nation at present. Rural America is abundant in natural resources and outdoor recreation. Again, this can lead to extensive economic development and opportunities. As I mentioned earlier, our population is growing increasingly diverse in rural America. This brings new businesses, new cultures, new ideas, and new perspectives. And when it comes to innovation and transformation of care delivery, one of the benefits of rural health is that there is often, depending on the system that you're working with, less red tape to create and implement a solution, which can make working in this space quite exciting. I'd like to share this quote before we move on to the clinical case. And of all the sort of the research that I've been tracking over the past year, this particular quote has stood out to me the most. It's as follows. The impacts of the coronavirus epidemic on rural communities will also have major implications for urban populations. Rural America supplies disproportionate shares of the nation's food, energy, military personnel, and natural amenity recreation. These are resources that urban America depends upon. Rural, urban, or somewhere in between, we are all in this together. And I appreciate this because you often hear the words of the rural-urban divide, and perhaps it's time that we start speaking about the rural-urban continuum instead. So I'd like to introduce you to a fictional case study. This is of Mountain Plains Family Health Clinic based in fictional Centennial, Washington. And I'll walk you through the details here on this slide. This is an independent private practice that has been in business for 20 years, again, in Centennial, Washington. It was started by two primary care physicians. Dr. Samantha Handler is a family physician, and Michael Handler is a general internal medicine physician. Over the years, they have grown to include two additional family physicians and two PAs. They offer a wide range of care and hours to their community, flexible hours and scheduling. The clinic accepts a wide range of insurance. They generally operate with 2 weeks cash on hand. And they once considered, applying to and becoming a rural health clinic and that federal designation, but given the administrative burden, they decided against that. The nearest critical access hospital with an attached nursing home is 20 minutes away. And the providers at this clinic have admitting privileges there. They also work in the emergency department. The town of Centennial itself is 4,000 people. There is a growing population of second home owners because there's a lot of tourism in this area that's causing some consternation in the community because the second home owners aren't as favorable toward new tax provisions in the community because they're not there the full year to benefit from those services. The largest employers now are the school system, the local fish hatchery, and vineyards that have a significant proportion of Hispanic and Latino migrant farm workers. And this family health clinic has a good relationship with local government, law enforcement, other employers, the school system, local public health, and the city council, which are critical for their work. So COVID-19 comes to Centennial, again, this fictional town in Washington. So in late March of last year, Dr. Handler received a call from Rachel Sisson. Rachel is the county health nurse. She let Dr. Handler know that COVID-19 had been detected in a nursing home 200 miles away. Both women very soon thereafter joined the local incident command team. And Dr. Handler was pretty concerned about some of the warnings from public health relative to PPE shortages, impending closures, and also worried about her husband, who happened to be the medical director at the nursing home 20 miles away. Their clinic has one long hallway, which made it difficult to make space changes relative to separating well and sick, but they decided to do that and to split those patients between AM and PM sessions. And one of their physician assistants is in her first trimester of pregnancy. And at the time that this took place last March, we weren't sure what the impacts of COVID on pregnancy might be. And so they had her doing mainly telehealth and phone visit and follow-ups. The incident command team recently added a local pastor and Chamber of Commerce members to expand their membership. They communicate frequently to the public via Facebook about testing and other issues. They're concerned that this may not be the most effective method to reach some of their Hispanic and Latino migrant farm workers in the vineyards, and the older population. I'm not sure how social media savvy they are in terms of accessing this information. So that's a concern for them. The local nursing home stopped in-person visits. The local public health department just ran out of swabs and reagents, and send-outs are taking 5 to 7 days to result, which is making it difficult for Dr. Handler and her team to provide isolation and quarantine guidance to their patients and community members. And of the 25 employees at the clinic, 15 had school-age children now at home. And they, at the end of March, they had their first case in Centennial. And fortunately, it was from a very cooperative second home owner that did stay home for the full 2 weeks of quarantine. So what's on Dr. Handler's mind at this point? Several questions. These are some. How would they continue to modify space at their clinic, in the case that numbers, dramatically increased? What would be the best local strategy for mitigating disease spread? How would she secure adequate PPE to protect her staff? And how could her team communicate most effectively about changing guidelines to their patients and community members? So I'd now like to introduce the playbook that I mentioned earlier. If anything, COVID-19 certainly has highlighted the frailties and fractures in our rural healthcare safety net over the past year. This is both a public health and an economic crisis in rural America, and it has been daunting, and it's also been distinctly felt and dealt with in different regions across the country, and again, even within the same state. In early December last year, the Farley Health Policy Center, where I am based, and the Colorado Hospital Association jointly released this playbook. This playbook was created based on over 30 interviews that were conducted with rural health leaders, clinicians, governance board members, public health leaders, and patients and community members from around Colorado, as well as an extensive gray lit and peer-reviewed literature search and data analysis. Quite truly, this is a playbook for a time and a situation when there really can be no playbook or a silver bullet of any sort for solutions. Each rural community has its own set of unique identities, challenges, and strengths. And these two hypothetical cases serve as the basis for which the playbook is built around. I've just started to introduce you to the Mountain Plains Family Health Clinic case. There's also a case based on Cerebell Health Center, which is a fictional rural hospital in northeastern Iowa. Now, although these are hypothetical cases, it's important to note that they very much reflect the reality for rural healthcare delivery systems on the ground. The goal of this playbook is to build rural hospital and primary care leadership capacities around strategic thinking and problem solving. A key feature of building leadership capacity is to know where it is that you're starting from as an organization and to have a clear picture of what your organization's strengths and weaknesses are, as well as barriers to success. As part of this playbook, we created a new rural-specific delivery system assessment tool to do just that. We found that many of the existing tools were limited or not as applicable in the rural setting for two primary reasons. The first is that many of the tools are very narrowly focused on one aspect of the delivery system, for example, assessing telehealth readiness. And secondly, that many of the tools developed more so with suburban or urban healthcare systems do not contemplate the differences in rural scope and scale, and quite frankly, the realities of providing rural healthcare in these communities. This tool assesses 5 domains: governance and leadership, community engagement, financial health, clinical care, and emergency preparedness and resilience. We chose these 5 domains because they are informative for an organization's ability to respond during a public health emergency. But public health emergency aside, these domains would also be insightful for understanding the general health and infrastructure of an organization. At the end of this tool, one does not get a score or a ranking, but it's meant to be taken as sort of an honest look in the mirror that can provide actionable insights into quality improvement opportunities. The playbook itself is divided into 9 mini chapters that align with the 9 most common COVID-19 challenges that we have seen rural healthcare delivery systems face over the past year. As you can see, my team and I appreciate alliteration, and so we have the 4 C's and the 5 S's of clinical care, communication, community, cross-system collaboration, and then space spending, staffing, statistics and surveillance, and supplies. Each of these chapters the content is structured similarly across all of them. Each of the chapters begins with a continuation of either of the 2 fictional case studies. There are strategic thinking prompts to help rural healthcare leaders decide for themselves how they would approach the answer to these questions and how they would solve the challenges. There's also practical guidance drawn from the peer-reviewed and gray literature review. Pearls from your peers or innovative solutions that were suggested during the key informal interviews that could be of utility to other users of the playbook. And lastly, additional resources to support rural healthcare leaders in their work. So let's return to this case, and I'm going to focus specifically on some valuable findings and points relative to cross-system collaboration, again, for Dr. Handler and Rachel in Centennial, Washington. So both of them at this point had grown pretty frustrated by the local public health department resource challenges and community criticism that the department had encountered a failure to test everyone. Rachel had also started to receive threatening calls about mask mandates, as well as threatening posts on the public health department's Facebook page. A local conspiracy theory emerged over the summer in that contact tracing was a plot to compromise privacy of local citizens for political gain. The closest critical access hospital, again, that was 20 miles away, seemed to be getting more financial assistance. They also had a more robust laboratory, social workers, case coordinators, and most importantly, seemed to have very active state politicians to help bring attention to what that critical access hospital needed. The Family Health Clinic decided it would have to engage the city council, the county commission, local churches, community-based organizations, and businesses to develop solutions for Centennial. And the question is, how could they do this effectively? Well, pulling from our research and the creation of the playbook, I would offer up these key factors that we had identified as increasing collective capacity for rural communities specifically to respond in these types of situations. The factors include a lean organizational structure at baseline, strong pre-existing community partnerships. And if you recall, this harkens back to one of the key assets of rural communities I mentioned around that sort of collective or community social capital. As well, a deep understanding of the local population, integrated healthcare and social service networks, interconnected data systems. Some rural communities are so fortunate to have those systems in place. A willingness to share supplies, funds, staff, expertise, whatever is needed. A trusted entity to serve as a communications lead. Respected community champions to help with that communication, particularly champions from the faith and the business communities, and a leader who is willing to recruit and engage volunteers. So what are some potential strategies for this clinic in Centennial? Again, from our research and informed by our key informant interviews and the production of this playbook, one of the many suggestions is to expand the notion of who could be engaged and who should be engaged in planning and response. A lot of rural communities I have witnessed over the past year are expanding their idea that emergency preparedness is everyone's responsibility, not just of the nursing home director or the rural hospital CEO or the community, law enforcement or public health or what have you, but it's the responsibility of leaders in the schools and businesses in the faith community, et cetera. Another strategy is to consider pulling resources to hire an emergency manager that could be shared across entities, to execute collaborative practice agreements to temporarily expand pharmacists' roles during a public health emergency, to partner with local nursing and senior homes to share not only personal protective equipment, but also to develop with them in-house triage workflows and clinical protocols to avoid transfer of nursing home patients to the hospital where they are more likely to be exposed. To also engage the state's cooperative extension service to support families who find themselves needing to isolate or quarantine and trying to work and educate at the same time at home. The Cooperative Extension Service in Missouri, for example, specifically to support families during COVID, developed a series of at-home science experiments, by video that children could engage in. They also provided a wealth of food and nutrition information to support families that found themselves cooking at home a lot more often than what they were accustomed to. And last but not least, tapping into the power of existing relationships. One rural community, the Postal Service typically delivered mail to post office boxes, and seniors had to come into the town to get their mail. They reversed this or changed things up a bit and had the Postal Service clerks and delivery personnel actually take the mail to the seniors' homes themselves, so they didn't have to come into town and get exposed. Another rural community on the East Coast created mutual aid societies where people could post what they needed and what they were willing to give and make that match happen. And then another community allowed remote healthcare personnel. Now, these are the folks who don't have patient-facing duties like HR, admin, finance, et cetera, that could work remotely to reduce the risk of exposure, but their homes in their rural community weren't wired properly, or they had very low broadband and bandwidth capacity. The schools were closed, so they invited those healthcare personnel to do their work remotely in the school where they had better Wi-Fi access. So now I want to switch to the last portion of the conversation, which is to talk about practical policy solutions with an eye toward equitable health outcomes between rural communities and urban communities. I'll start first with the immediate and the near term. And I will preface this by saying that it is challenging to think about reducing disparities and achieving equity between rural and urban populations in the midst of a crisis. You are moving from one thing to the next, and whether you're in a rural healthcare delivery system or where we are here in the Denver metro, we can certainly appreciate that sentiment. In terms of near-term practical policy solutions to make sure that our rural communities have access to what they need, providing financial assistance to primary care, to rural hospitals, if and as needed to help them stay open and serving the public, to ensure access to needed supplies as well as staffing, and to create rural-specific vaccine plans and how to leverage primary care and trust and relationships in the context of this plan, and also to contemplate what does it mean potentially with a Johnson & Johnson vaccine coming onto the scene relative to reaching physically harder to reach populations in some certain rural circumstances. So switching from the near term to the long-term policy solutions. This is an article that I recently had published in The Conversation with a colleague of mine from Southern Illinois University that outlined 5 innovative ways that the new administration could address and help transform rural healthcare. These solutions I'll highlight from this piece as well as others that I think are important to pursue. I group into 3 buckets. The first is to innovate payment and delivery. The second is to invest in transformational leaders and infrastructure. And number 3 is to strengthen collaboration with community partners and to build upon, again, that community social capital that is an asset in rural communities, generally speaking, and to build upon partnerships that have been forged in the context of this public health emergency that should not unwind themselves as we start to recover and emerge from COVID-19. So I'll start first with innovating payment and delivery. I would love to see a rural-focused division established at the CMS Innovation Center. The Innovation Center was created by the Affordable Care Act to design and test new payment and delivery models with a focus on improving the quality of care and reducing cost for Medicare, Medicaid, and CHIP beneficiaries. Innovation in the rural space when it comes to payment and delivery is a different beast entirely than it is in urban settings. It's not to say that rural and urban can't learn from each other in this way, but in rural America, again, as I established earlier, greater health disparities. So you have to manage that at a baseline and think about what is possible in terms of delivery, care delivery transformation. You also have populations that are more physically dispersed. You have lower volumes, and lower volumes have significant implications when it comes to risk bearing in new payment models in a value-based world, as well as how you accurately or effectively measure the impact of the interventions, that the payment and delivery interventions that you are doing. It's important to continue to experiment with new payment and delivery models. One that I am particularly familiar with is the Pennsylvania Rural Health Model. When I served as Deputy Secretary for Health Innovation in the Pennsylvania Department of Health, that was my prior position before coming to CU. I was part of a design team between the Commonwealth of Pennsylvania and the Innovation Center to design the rural health model. This is a new multi-payer global budget model designed specifically for rural hospitals to provide them not only financial predictability and sustainability, but also a pathway to transform from volume to value. In addition to helping co-design that model, I oversaw the launch of that model, and it's now in its 3rd performance year. 2 other payment and delivery innovations that I would love to see happen in rural healthcare. The first is expanding access to mental health and addiction services. Rural health clinics offer a pathway or a venue to be able to do this by changing billing rules so that they are akin to what federally qualified health centers can bill for. Again, the opioid and heroin epidemic and other substance use disorders are prevalent in rural, and certainly, there have been significant mental and behavioral health challenges beforehand that are now compounded by COVID-19, and so to have access to those services locally is really critical. And then maternity care payments at critical access hospitals. This would be a heavy lift, but it would be one that would have significant impact. Many rural hospitals either are closing or they are closing their OB services, which is creating substantial maternity care deserts in rural America that really set up and the challenges that are leading to increased maternal and infant mortality in rural America, particularly when you think about the intersectionalities in certain areas of the country of rural and race, rural and gender, rural and other sorts of demographics. With regard to enhancing maternity care payments, it could be an opportunity to increase dedicated OB nursing coverage at rural hospitals, and also would reduce the need for a rural hospital to open other expensive surgical lines to try to generate enough revenue to cover the 24/7 anesthesiology coverage that is required when you offer OB coverage and OB services at a rural hospital. The second bucket of suggestions is around investing in transformational leaders and transformational infrastructure. When we think about rural physicians, there's a significant pipeline and investment that is made to create this pipeline. There could be abatement of medical school tuition, loan repayment and scholarship programs, rural training tracks. Now think about what's the pipeline for creating rural hospital administrators and rural public health leaders. There aren't any, as far as I know. And this is a significant challenge and a gap that could be addressed in a variety of ways. It's also important to expand rural GME training opportunities, whether it's a funding model akin to teaching health centers or thinking about expanding rural training tracks or rural training slots. Linking rural healthcare infrastructure dollars to innovation will be essential moving forward. A lot of our rural hospitals and rehab centers and nursing homes and other healthcare facilities are in dire need of infrastructure repair. A lot of these hospitals were funded by federal construction dollars that flowed from the 1946 Hill-Burton legislation to create these very facilities. As you can imagine, for those that were built in the 40s and the 50s and the 60s, that many of them are, again, in dire need of repair. But I think it's critically important that those infrastructure dollars would be tied to new rural healthcare design and delivery concepts in exchange for that investment in infrastructure. And last but not least, important for rural communities and for the state and federal governments to invest in health promoting infrastructure, whether this is community centers, bike paths, accessible playgrounds, etc. The USDA, in terms of on the federal level, has quite a few sort of grant and loan programs to this extent, but they certainly could be expanded. On the third bucket, strengthen collaboration with community partners. As I alluded to earlier, primary care and public health and rural hospitals have in many ways and for many communities partnered during COVID-19 in ways that they have never partnered or even talked to one another before. And I don't see any reason why that collaboration and partnership needs to stop as we enter a recovery phase relative to COVID. Each of the three of those players offer very unique services that only they can do. That is true. But those three do overlap and have shared interests and priorities around evidence-based prevention, around population health, nutrition, fitness, reducing obesity, for example. This is the part of the Venn diagram between primary care, public health, and rural hospitals that overlap and represent a great opportunity for continued partnership moving forward. Number two is to pursue greater access to broadband across healthcare, businesses, schools, and local organizations. Fairly self-explanatory, certainly would help not just healthcare, but those other sectors mentioned there as well. And after we emerge from COVID, I think it'll be important to continue community emergency preparedness activities. Prior to COVID-19, many of the rural healthcare leaders that I spoke to last year indicated they routinely conducted tabletop exercises or sort of fictional case studies around who would do what, when, where, and how if an emergency arrived in their community. Many of these same rural healthcare leaders said, though, that a lot of their tabletop exercises focused on mass casualty incidences, agricultural chemical spill, fires, floods, etc. but very few of them had infectious diseases contained within their tabletop exercise sort of lineup. And a lot of them said they definitely plan to do that moving forward. I think it's important within the community to revisit incident command structures and then to consider regionalization of supplies, staffing, and testing models, particularly during public health emergencies. So rural hospitals and rural primary care practices are not having to go this alone and figure out all of these nuances themselves in the midst of a crisis. And last but not least, I would also contend that the following is incredibly important, that perhaps the most effective strategy for improving rural healthcare delivery and rural health policy is to ensure that trusted leaders with lived rural experience and expertise are in positions where they can shape policies that respect rural culture and context. And borrowing a line from the musical Hamilton, to make sure that rural people are in the room where it happens. A lot of times, I think rural communities perceive that policies and believe that policies are made for them, but not made with them. And we have an opportunity to change that. So thank you very much for your attention during the talk. I have provided here a couple of discussion questions, but also I know I've been seeing some questions coming up in chat, and happy to take those questions, or we can start with these as well. Dr. Albert, I'll turn it back over to you.
Well, thanks very much for the interesting presentation. One thing that struck me as interesting was that many of the problems that you elucidated with respect to supplies, staffing, vaccine distribution, the frequency of conspiracy theories, primary care practices, issues related to primary care, those are the same issues affecting urban areas. There's no difference. There's no real unique rural aspects of those, I don't think.
That's a great question, Dr. Albert. And I would agree with you and also disagree with you. So I would agree with you in the sense that those are similar challenges between rural and urban settings. Where the difference lies, though, is in how you solve those problems. In rural,
that I would agree with, yeah.
And because as you can appreciate, for other reasons I mentioned throughout the talk, is that there's, there are different resource levels, different capacity, different bandwidth, et cetera, and just different physical distance, lack of the connectivity and broadband and so forth, that makes you have to take a different approach to solving those problems. And which also sets up the argument that to take an urban or a suburban solution and say, here you go, rural healthcare system, you can imagine that there may be poor fit. There could be some aspects of that could be useful, but depending on what it is, it may be a challenge. So,
well, I mean, every hospital in the country was, or at least the large majority of hospitals in the country were falling all over themselves, trying to find enough nurses to help take care of the patients during the surges.
Absolutely.
And it's no wonder that those nurses, the travelers, were making, a
lot of money,
lots of money each week to help out. Maybe an urban environment or a hospital that receives more greater distribution from the federal government can afford to pay those prices than a smaller rural hospital. But the problem is still the same. It's not necessarily a rural problem, but the solutions certainly have to be changed to a different scale.
No, I agree. And on the nursing front, I heard, stories and lived experiences from those that I interviewed, the rural health leaders I interviewed last summer, whose nurses, resigned. The very next day, their name pops up on a list as a traveling nurse, as a staffing in a staffing agency. But as you say, the margin to be able to afford those prices and for a rural hospital in a vast majority of cases is they have to pass on by and make do with what they have, because they cannot afford those prices.
Um, I wanted to take broadband expansion off the table because there's lots of reasons why that has to happen that aren't associated at all with healthcare. Even without healthcare, broadband needs to be expanded nationwide.
A public utility.
Yeah, but aside from that, a lot of the things that you talked about would seem to be very expensive. Did you envision this as a zero-sum game, or are we talking about major financial investments in rural America?
I would say that for a lot of these policy solutions, there's a mix. Some of these can be regulatory changes to allow some of these policy recommendations to move forward. But you are correct that there would be a lot, and I don't have a price tag, for you today, but there certainly would be other solutions that would require additional investments, depending on what the policy, solution is. I don't think that, investment in rural healthcare, many other rural sectors has been, challenged over the years. So to pursue a zero-sum game, it doesn't seem like we're going to result in the types of solutions that will, benefit rural people and places by pursuing that game. But I think really authentically investing in rural communities will be critical moving forward.
You mentioned the landmass discrepancy, or urban versus rural. What do you have any feel for the population separation? What percent of the population is urban versus, I guess, not urban? You had micropolitan and semi-rural and rural.
Sure.
Adding all those up together, do you have any idea what the fraction of the population is that lives in other than urban environments?
So altogether, it's roughly an 80-20 split. So 20%,
Yeah.
one in five Americans live in rural, and then one of those five of the 1 in 5, identify as a person of color or Native American. So it's roughly 80-20 split. Now, exactly how that breaks down with micropolitan and semi-rural, I don't have those numbers for you today.
Yeah.
But
That was another question I wanted to ask you. That graph of the semi-rural, rural, micropolitan, that was an interesting graph, as you suggested. But I noticed that the percent of people that were over 65 was markedly bigger in rural than in micropolitan or semi-rural. And I wondered how those three classifications were devised and why there is such a big discrepancy in elderly folks living in rural as opposed to semi-rural or micropolitan.
No, it's a great idea, or great question, rather. Again, the micropolitan definition is, from the Census Bureau, is between 10,000 and 50,000, individuals. The semi-rural, I don't have that specific definition for you, or the distinction between that and rural. I would need to pull those, from the Census Bureau and go back to the original data that Dr. Peters put forth, in his study to see how he broke those out. I would say that from my own, lived experience and the research that I have done, I'm not at all surprised by that distinction of seeing a greater proportion of 65 plus in rural America. Those are my parents you're talking about in rural Iowa, right? That we're seeing, sort of those demographic shifts over the past decade or two of younger people leaving those rural communities to seek economic opportunities and educational opportunities elsewhere, and realizing when they get through their training and they come back that there aren't the opportunities they need in rural communities, which, going back to broadband, would be hopeful that if broadband could be expanded, there are a lot of jobs that one can do remotely, and we have collectively demonstrated that over the past year, both in rural and in urban settings. And so I think a lot of those demographic distinctions are based on sort of population shifts and who's choosing to stay and who's choosing to leave rural communities.
Mm-hmm. The last thing I'd like, from my perspective anyway, to comment on is the GYN issue, OB issue. to me, I'm not sure. I don't see a solution to the problem of finding the right setting where the volume of need meets the volume that an OB doctor or a group of OB doctors and anesthesia doctors that are going to be necessary for 24/7 coverage.
Mhm.
How can you determine the volume of need and match it with the volume of services so that it's anywhere near economically feasible, number one, and number two, quality of life for the practitioners? I mean, no one's going to
Sure.
want to work and deliver 8 babies a month.
Mhm.
You know, they could do that in an afternoon at an urban center. So how do you go about putting those two pieces
No,
together?
you've went right to the heart of which is a very challenging policy matter, and as well as the potential solutions. The other thing that's important to keep in mind too is that full scope family physicians also can do OB as well as
Yeah.
operative OB, and so with additional training, and that's a lot of who you find in rural communities are full scope family physicians, because to your point, an OB might be a higher price point, but also relative to, an OB is, if they're a generalist OB and doing, labor and delivery and obviously surgical OB, they need to reach a certain volume to keep up their skills. It's a different scope in thinking about full scope family physicians doing operative OB in those communities. And so that's a difference in the workforce. But to your point, Dr. Albert, of sort of balancing the need and the drive and the volume, and thinking about making sure that it's safe and high quality care. This may be an opportunity for rural healthcare delivery systems to think about broader partnerships or ACOs or models like this that allow them to regionalize where certain services can be provided, and that could be a way to potentially approach that.
Mm-hmm. Good. Well, it's 1 o'clock on the button, so thank you very much for the provocative presentation. It was interesting to hear something discussed we don't talk about very often. So thank you very much.
My pleasure. Thank you so much. Have a good rest of your day.